Okay, I can hear you. Okay. All right, thanks. So I have to, by law, be able to hear the one.
Yeah, it's okay.
That treatment.
I have one
usually,
question.
Yes, ma'am.
I understand what you were saying about the differences. There's no real advantage or disadvantage. But what about the salivatory glands? Is it easier on the salivatory glands?
Nope, no difference.
The proton versus the...
No difference whatsoever that has been established in any particular study that's been conducted. What we do is, again, something known as intensity modulated radiation therapy, which is when you have a target and right next to a target is a particular structure that you're trying to spare radiation dose to, the way in which the beam profile comes out of the machine and how we're able to modulate the beam as it comes out of the machine makes it such that at one point the dose can be X, a point very next to or proximal to that could be X plus or significantly less than X, dependent upon what it is that we wish to do. So basically, you can actually treat from multiple different directions like we do. You can give a little radiation from this direction, a lot from this direction, and as you do that, you're kind of, in addition to that, modulating kind of how the beam comes out of the machine such that the target can have variance of dose across really the field of what it is that you're treating. So again, if you're wanting to protect this structure, but actually blast a structure very close to it, the computer technology of the machine and how the beam of radiation is delivered allows you to do that. So that, when we look at really comparisons of treatment plans with proton beams versus photon beams, what you're looking at when you look at that is really kind of the dose across the volume and how they really kind of look. Again, can you actually give a dose at this point and then you're next to it, change that dose either up or down dependent upon what you want to do. You're pretty much able to do that with a photon beam if you have IMRT capabilities. Now, in all honesty and sincerity, there is a prettier dose painting picture that is rendered with a proton beam, but with respect to how that trickles down to you and your side effects and dryness of mouth and all that sort of thing, there is no significant. The incidence of xerostomia, dryness of mouth, there's a good chance of that. Yes, there's a good chance that you will have significant reduction in your salivation. There is a governing body known as the Radiation Treatment Oncology Group, which looks at the practice of radiation oncology in this country across the board. And because we're always trying to improve what it is that we do as physicians in this particular discipline, radiation oncology, you're constantly evaluating what's done. Okay, for this particular malignancy, how is it treated? What dose are you treating people to? What are the outcomes of your treatment? And that's really kind of the way medicine is going in this country, sort of a standardization of treatment, but not only that, a quality assessment of how people do in the hands of specific physicians, okay? So in saying that, the governing body that looks over all the research that's pretty much done in this country in radiation is the RTOG. And they basically have specific guidelines that sort of mandate what it is that's acceptable with respect to various critical structures that you want to protect as we give people radiation, such as the spinal cord. In the head neck patient, it's the spinal cord, it's the brain stem, it's the salivary glands. We also want to be cognizant or mindful of how much radiation we're giving, really your oral cavity, a mouth, a part of you that is near where we need to treat but doesn't have any tumor involvement. We want to keep the dose of radiation low to that structure, your larynx. So again, there's a governing body that sort of says, okay, these are the constraints that your dose should be within for you to have an acceptable treatment plan, and we adhere to those particular guidelines when we generate our plans. Having said that, the proton people, they do the same thing. Again, there's no difference in really the radiobiologic effect of a radiation treatment with protons versus photons. It's the same dose effect. But again, the beam profile and the dosimetry can differ between the two. And again, to be honest, a proton beam will give a prettier profile with respect to how the dose varies across the field of treatment. But with IMRT, you're able to do things that are very, very, very similar, to the point that there isn't any real difference in what a person's experienced side effects are, at least as it is in this day and age. Now again, as I mentioned earlier, the advance of technology and the improvement of machines and the delivery of radiation, with respect to what we do with photons and really what's done with protons, that will continue to happen. Things evolve. 20 years from now, 10 years from now, I may not be able to sit here and tell you that in honesty and sincerity that the two are equivalent. But as best we know at this point, with published data and with things that have actually been looked at, and have assessed and answered this question, there is no advantage necessarily to you being treated with one versus the other. However, you have to be comfortable with where it is that you're going to get your treatment, who's going to treat you, and really, if you're motivated to be treated with protons, again, I have no negative things to say about those people, because they're the people who train me, at least the older ones down there. But again, you have to be comfortable with what it is that you're going to do. I need to finish your exam, and then we'll get through to all of your questions and everything.
You're going to be a good politician one day.
Huh? Oh, no.
You're an excellent speaker, I'll tell you that.
I don't know.
Not that 15 years, we've got that. Who's that doctor? Doctor
Carson?
Carson. I'd love to hear him speak. Every time remind me.
He has a very amazing story, actually. He really does.
He was, what kind of doctor was he?
Pediatric neurosurgeon at Hopkins, actually, is what his background is, at least from a physician standpoint. Let me get you to swivel a little bit towards me here. All right, what I'm going to do is slip this down one of the openings there. I'm going to go down the right side, left side, rather. Yeah, no. It's just someone's changed the setting of the lens there such that I can't focus as well. Blurry. Yeah, first. No contacts or
You'll be over time to do 4 years of college and 8 more years
go ahead.
8 more years of doctorate.
That's correct. 4 years of college, 4 years of medical school, and 5 years of learning what you're going to do, at least. Okay, so breathe nice and easy, okay? Look through your nose and your mouth. Okay, breathe through your mouth. Okay, breathe through your mouth. Levels. And lateralize to on the right, on the left rather, on the right side. You okay? Yeah. All right. Just getting past to your voice box here. Say E. And then it's fine there. Back a little swallow for me. Swallow again. So it's over there on the.
Seen this 3 or 4 months ago in there.
Possibly, I would say within the last 3 to 4 months, this would have been visible. Yes, sir. Let me just reach down and take a feel of that area there. You have a real bad gag reflex?
We'll find out.
Okay.
I'm sure
All right. Just open real wide and. Okay. All right. Take a big deep breath. Let me just reach back there one more time. Yeah. Thank you for not kicking me. Big deep breath. Okay. All right. Oh, sorry about that. Okay.
How do you feel?
All right. That's just the tumor itself as it extends into the molecular. So, on your exam, as is evidenced by the CT scan, you can relax back over there. It might be a little bit more. As is evidenced by the scans that you have a lymph node over in the left neck, measures about 2